Hi guys, this is JAIMIN Singh Rao, and today in this topic I will discuss about the chemotherapy of protozoal infection. That is ultimately our aim to discuss about the anti-protozoal drug in pharmacology. So begin with the first topic, that is anti-protozoal infection. So what are the protozoal infection? So first is malaria, hemibiasis, giardiasis, trichomoniasis, trypanosomiasis, leishmaniasis, toxoplasmosis, babesiosis, balantidiasis. So, so amoebiasis is a first topic. Then we move further. That is definition. So amoebiasis is an infection with a parasitic intestinal protozoa, Entamoeba histolytica, the tissue line amoebia. Amoebiasis is a majority health problem. So the 10% world population, 50 million people with the invasive disease. Death is 1 million of this annually. Third most common cause of death from parasitic disease after malaria and schistosomiasis. So schistosomiasis, so more common in seen with poor sanitation and crowding, compromise barrier of contamination of means foods, and that is related to this. So modes of transmission. So how these are transmit? So have given in the picture, you can see that here it's a very good picture. So the fecal contamination of the drinking water and food, but also by direct contact with dirty hand or object, as well as sexual contact. Additionally, geophagy is common route of infection in certain culture. So we move further. So our not to be severe factor contribute to infection. So what are the factors which from where this infection is become a severe? So there are two. We will divide this factor. That is, one is a host factor, another is a risk factor. So these are consequences of these factors. So host, we will discuss about the host. There is a stress, malnutrition, alcoholism, corticosteroid therapy, immunodeficiency, and alternation of bacterial flora. And in a risk factor, people in developing country that have a poor sanitary condition, immigration from developing country, traveler to developing country, HIV positive patients, and male who have a sex with male, that is homosexuality. So these are the very several factors of risk factors. So life cycle, we will discuss about the life cycle of the amoebiasis. So you can see that this is a cyst. Infective form can survive outside the body, transform to trophozoites. Trophozoites, non-infective, invasive, can reproduce, feed on intestinal bacteria, or invade and ulcerate wall of large intestine, and may migrate to liver or other tissue, transform to cysts, which are excreted in feces. So guys, here we will discuss about the life cycle. So how the life cycle of the amoebiasis will happen. So begin with the first, that is our mature cyst. So here as given mature cyst. So mature cyst is ingested by the human in the respiratory tract. From the respiratory tract it goes to stomach and to the intestine. So here you can see that first, that is our affecting our large intestine, you have shown in the diagram. And after this large intestine, it also affect the intestinal disease. So it causes an intestinal disease, and due to this intestinal disease, it is absorbed in our routine circulation and goes to the liver, and it is extra intestinal disease caused by this type of disease. So ultimately travel to the brain, and it is a very complicated thing for to understand this. So it is very, as shown in the diagram, that there is a symptoms like a intestinal problem or extra intestinal disease which caused by the amoebiasis, and here it go in the brain and cause disease. On other hand, this mature cyst is divided further into the excitation station, and further third step is our tropozoid. So this tropozoid is multiply and it forms a cyst and tropozoid. So here it is a diagnostic stage, and you can see there here that is a where diagnostic identified by the D. So the triangle D is a diagnostic stage, and the where the F is written, so it is a stage of the infection. So you have to know that the properly about this type of the life cycle, because to understand the medicine, to understand the pharmacology about this, so to understand, to know about the there should be a know about the life cycle. So you can see once again, this is a very important for the understanding of the amoebiasis. So further after this, the second step is our feces. In the feces you can find that these are the diagnostic criteria or diagnostic stage after we will say that this is a kind of infectious disease or in kind of the amoebiasis disease. So classification of anti-amoebic drug. So we will now further, our main topic is to study the pharmacology. So the classification of anti-amoebic drug are tissue amoebiacids, luminal amoebiacid. So two type we have divided as shown in the PPT. So first we will discuss about the intestinal and extra-intestinal amoebicidas and amides. So in the tissue amoebicides and luminal amoebicides, so the tissue amoebicides, nitroimidazoles, that is our drug that is very important. These drugs are so metronidazole, tinidazole, ornidazole, secnidazole, satranidazole. Okay. In about alkaloids, imidine, dihydromethane. Extraintestinal amoebicids, that is chloroquine. It is also used in the malarial drug. That is also in we will talk about the luminal amoebicids, that is amides. So in this there is a diloxanide, forate, nitazoxamide. For talking about the 8-hydroxyquinoline, so quinodochlor, idochlorohydroxyquil, and given in the diagram. So these are the drug of the luminal amoebiacids. So antibiotics like a tetracycline also we can use in this. Metronidazole is very important and it is a drug of choice of the amoebiasis. So we have to discuss about the metronidazole, very important drug for study. So you should have to be concentrated at this place. So we will first discuss about that is our metronidazole. So originally discovered and used for trichomoniasis in 1959 as given. So the chemical name, that is 1-beta hydroxyethyl 2-methyl 5-nitroimidazole. So nitro group on C5 is essential for its activity. That's given in the diagram. So antimicrobial spectrum. So antimicrobial spectrum, broad spectrum sedal activity against entamoebic protozoa. There are three listed given, that is E. histolytica, T. vaginalis, G. lambia. So the anaerobic bacteria that cause this type of anti spectrum. So anaerobic B. fragilis, Perfringens, H. pylori, definitely Fusobacterium, Campylobacter, Peplococci, Spirochetids, and anaerobic streptococci. So guys, here you can see that we will talk about the extraction and adult guinea worm. So guinea worm, so Dracunculia medinensis. So resistance, we talk about the resistance. No significant resistance of entamoeba histicoa till now developed for T. vaginalis, Troponium validum, T. vaginalis. Okay. Mechanism. What is the mechanism action of the metronidazole? So selective toxicity of to anaerobic and microanaerobic microorganisms. A system unique to anaerobics, pyruvate ferrodoxin oxidoreductase pathway PFOR normally generates ATP via oxidative decarboxylase of pyruvate. So you can see that the pyruvate is converted to acetylcholine. So there is an enzyme that is ox ferrodoxin and PFOR, and it converted into the red ferrodoxin others. So ultimately their aim is to oxidative damage. That does not oxidative damage. There is our ultimately aim. So you can see that this is a reversible, and R means the enteric site which of the in the chemistry. So ultimately our aim is to oxidative. So it is a sequential cycle shown that entry into the microorganism by diffusion. Nitro group is reduced by redox protein to high reactive nitro radical. Nitro radical act as an electron sink. So further our aim that is. So the nitro group is reduced by redox protein to high reactive nitro radical. Nitro radical act as an electron sink, competes with biological acceptor sites of anaerobic organism for electron gene by PFOR pathway of pyruvate reductase. Metronidazole in addition inhibits mediated immunity, cell mediated immunity, induce mutagenesis, cause radiosensitization. Pharmacokinetics absorption from 4 types. Completely absorbed from the small intestine, little amount reaches colon. So the T half, that is 8 hours. Less than 20% bound to plasma protein and total body water. Okay. Therapeutic uses amoebiasis, first line drug among all forms of amoebic infection. Current recommendation: invasive dysentery and liver abscess, 800 mg TDS for 7 days. Severe case of amoebic dysentery or liver abscess, 500 mg IV infusion 6 to 8 hours for 7 to 10 days or till oral therapy can be started. Mild intestinal disease, 400 mg TDS of 5 to 7 days. As here in the giardiasis, so highly effective in dose 400 mg TDS for 7 days. Shorter course of 3 days with a 2 gram per day equally effective. In T. vaginalis, Trichomonas vaginalis, drug of choice is 2 gram single dose preferred. Anaerobic bacterial infection occur mostly after colorectal or pelvic surgery, appendectomy, brain abscess or endocarditis may be caused by anaerobic organism. Metronidazole is in combination with a gentamicin or a cephalosporin effective. Severe case IV administration recommendation: prohydrolytic use in high risk situation, colorectal or biliary SX. So other drug in anaerobic infection: clindamycin and pseudomembranous enterocolitis, 400 to 800 mg BDTS for 10 days to 14 days, more effective, more convenient, less toxic, and prefer over a vancomycin. So the sixth use is that is a Helicobacter pylori, gastritis or peptic ulcer. So metronidazole 400 mg TDS or tinidazole 500 mg BD plus amoxicillin, clarithromycin, and our last aim is to in the peptic ulcer, that is our proton pump inhibitor. Triple drug for 2 weeks. Acute necrotizing ulcerative gingivitis and ANUG. So also called the trench mouth caused by anaerobes like Fusobacteria, spirochetes, bacteroids. Metronidazole, tinidazole drug of choice. Gunia worm infection, nitradazole drug of choice but available unavailable in India. Okay, you remember this word, that is, it is not available in India. So metronidazole, it is local reaction suppress anti-inflammatory reaction, extraction facilitation. Drug dose कितना होगा? तो 200 to 400 mg TDS for 7 days. एडवर्स रिएक्शन की बात करते हैं आप दोस्तों. इट्स वेरी important also. Metronidazole is a drug of choice in the amoebiasis, so it is very important drug. So you have to learn everything about the metronidazole properly. So most common anorexia, nausea, vomiting, abdominal cramps and metallic taste. Less frequent headache, glossitis, rash, dryness of mouth, dizziness and loose stool. Urticaria, flushing, itching, rash and fixed drug eruption occur in allergic subjects. Warrants discontinuation and precludes further use. Prolonged administration, peripheral neuropathy and CNS effect. Seizures at high doses. Contraindication, first trimester in pregnancy due to mutagenic potential. Neurological disease and blood dyscariasis. Chronic alcoholism. ये बहुत ही इम्पोर्टेंट है, दैट इज़ आवर डाइसल्फिराम लाइक intolerance to alcohol occur in some patient with taking metronidazole. This should be a very important point of viva purpose. Disulfiram like intolerance to alcohol occur in some patient taking metronidazole. So what are the symptoms? Symptoms: flushing, burning sensation, throbbing, headache, perspiration, dizziness, vomiting, visual disturbance, mental confusion, fainting and circulatory collapse. So ultimately we have got the tinidazole, that is another drug of the amoebiasis, situated for single dose or once daily therapy, metabolized slow, T-half 12 hours, longer duration of action, high dose, high cure rates, better tolerated, low incidence of side effect like nausea 8%, rash 0.2% and metallic taste 2%. Therapeutic uses: intestinal amoebiasis, amoebic liver abscess, trichomoniasis and giardiasis, high H. pylori and anaerobic infection. Another 3 drug that is these are also important, but drug of choice is metronidazole. So these drugs are, so first we discuss about the secnidazole. Okay, what is the secnidazole? Congener of metronidazole with a similar spectrum of activity and potency. Rapid and complete oral absorption. Slow metabolism. T-half is 70 to 29 hours. Single 2-gram dose, high cure rate. Side effect similar to metronidazole with incidence of 2 to 10%. So, or another that is ornidazole. Similar activity to tinidazole, slower metabolism. T-half is 12 to 14 hours. Dose and duration of regimen similar to tinidazole. Side effect is similar to tinidazole. Last but not the least, that is cetronidazole. Longer T-half 14 hours. Better tolerated, no nausea, vomiting, metallic taste, absence of neurological and disulfiram like reaction. Another this is came here, that is disulfiram like reaction. So doesn't produce acetobolite metabolite which is a weak carcinogen. Alkaloids, there are 3 types, that is imethidine, dihydroimethidine and chloroquine. So imethidine and dihydroimethidine. So chemistry: emetine and dihydroemetine. So emetine, hydrochloride, plant alkaloids derived from Cephalius ipecacuanha. It's a very difficult to pronounce this name, my god. But we have to do this. Okay, so Cephalius ipecacuanha. Once again, Cephalius ipecacuanha. Yes, we got it. Dihydroemetine synthetic analog. You can see that this is a structure of dihydroemetine. So not a imidine, it is a dihydroemetine. I have mistake before speaking and the spelling pronunciate. Sorry for that. We will move further. Mechanism of action. So what is the mechanism? There are three steps: inhibition of intra-ribosomal translocation of tRNA amino complex, inhibition elongation of peptide chain, inhibits protein synthesis, effective against ट्रोफोजोइड्स ओनली. ओ ट्रोफोजोइड्स में ही इफेक्टिव है. पोटेंट रैपिड एक्शन बट नॉट क्यूरेटिव. Oh my god, this is also another. It also need one tick. Uses: amoebiasis like abscess in intestinal wall infection, severe forms of amoebiasis, acute amoebic dysentery. Dihydroemetine is preferred as it is a less toxic to heart and less cumulative. Seldom used, not only for patients not responding to metronidazole. Very important point. Remember guys, seldom used, not used now, only for patients who are not responding to metronidazole. Luminal amoebicides must not be followed to eradicate cyst forming trophozoites. Adverse reaction: local irritants, pain, tenderness, even abscess formation or at site of the injection is most common. Gastrointestinal tract, that is discomfort, nausea, vomiting, diarrhea due to CTZ, that is our stimulation, and gastric irritation most frequent. Abdominal cramps, neuromuscular blockage, muscle weakness, muscle stiffness, cardiac toxicity, arrhythmia, hypotension, tachycardia, myocarditis, and ECG changes. Not be used in a patient with a cardiac and renal disease in a children or in a pregnancy. So this is important to remember. So chloroquine, another chloroquine kills trophozoites of Antibiotica histolytica, highly concentrated in a liver, used in a hepatic amoebiasis, completely absorbed from the upper intestine, not effective in a invasive dysentery or luminal cycle. Effective in amoebiasis, amoebic liver abscess is equal to emetine but has longer duration of treatment and frequent relapse. Used for course of metronidazole, but in a luminal amoebicides must be added. Diloxanide furet, highly effective luminal amoebicide, kill trophozoid responsible for production of cyst, however no antibacterial action. Diloxanthin furet, hydrolyzed, so the diloxanide plus furoic acid. So diloxin is divided into two parts, that is 80 to 90% of free diloxanide absorb, no systematic effect, and 10 to 20% not absorb, real anti-myobic surface. Metabolized by glucuronidation and excreted in urine. So uses, we talk about the uses. Single course produce high curative 90%. Mild intestine amoebiasis, asymptomatic cyst passers, tissue amoebiasis and liver abscess with metronidazole. Chronic cyst passes require repeat course of eradication. Dose, that is a 500 mg TDS for 5 to 10 days. Adverse reaction: well tolerated, flatulence, nausea, itching, rarely. So another drug, that is a nitazoxanide. So salicylamide, congener of antihelminthic niclosamide, introducing for treatment of giardiasis and cryptosporidiosis. Spectrum: G. Lamblia Cryptosporidium parvum, also effective against Antiboica histolytica. T. vaginalis, H. pylori, ascaris. So pharmacokinetics product convert the tizozanide after absorption. MOA. So MOA tizoxanide inhibitor of PFOR enzyme essential for electron transport energy metabolism in anaerobic organism. Uses giardiasis, amoebic dysentery as a luminal amoebicide. Most effective for cryptosporidium infection, 88% causing diarrhea in children and AIDS patients. So adverse reaction, that is a mild and infrequent abdominal and vomiting headache. 8 hydroxyquinolines. It is divided into two types, that is a quinodocler and diodohydroxyquine, idoquinol. These are very difficult pronunciation. This name is very difficult to pronounce it, but if we come going, I hope there will be one day when we pronounce very well. So I can also pronounce this with little bit hard, but I will continue this. So I will try again with you. That is quinodoclor diiodohydroxyquine. Very good. Idochlorohydroxyquine, cleoquinol, idoquinol. Yes, I can. I can read very fastly. Quinodoclor, idohydroxychloroquine, idoquinol, idochlorohydroxyquine, chloroquine. Yes, I can do. Oh, a spectrum. If we discuss about the spectrum, so active against entamoeba, giardia, trichomonas, some fungi, dermatophytes, and candida and bacteria. 8-hydroxyquinolones uses alternative to DF in intestinal amoebiasis, chief and good acceptability. Giardia, local treatment of monilial and Trichomonas vaginitis, fungal and bacterial infection. Adverse reaction, once a popular drug but less now because of adverse reaction. Well tolerated, only nausea, transient loose and green stool and pruritus, but if used improperly have a toxic potential. Iodism, goiter may develop, so we have to very it is a chance of hypothyroidism, so it will be a difficult. So inflammation of the mucous membrane, furunculosis. Those sensitive, acute reaction with a fever, chills and angioedema and cutaneous. With the prolonged and repeated use is relatively high dose cause a neuropathic syndrome, so subacute myelooptic neuropathy, say SMON, subacute myeloid optic neuropathy. So inflammation of optic nerve, complete or partial loss of vision and peripheral neuropathy. In India, prohibited for pediatric use for chronic diarrhea and use cause blindness. Fixed dose combination except for external application ban in India. Causes more caution note is inserted that use in high dose for more than and antibiotics tetracycline. So mechanism of action, direct inhibitory action on entamoeba. So the last antibiotics, that is tetracycline. So older tetracycline absorb incompletely, large amount reaches colon, inhibits bacterial flora with entamoeba lives symbolically, indirect reduce proliferation of entamoeba. Uses chronic case of conjunction with more efficacious luminal amoebicide, management of amoebic dysentery, added as a third drug in combination with a nitronidazole and luminal amoebicide. So last drug, that is a paromomycin. Aminoglycosides resembles neomycin. Spectrum: Entamoeba histolytica, G. lamblia, Cryptosporidium, Parvum, and T. vaginalis, Leishmania, and some type tapeworm. Antibacterial spectrum similar to neomycin. Mechanism of action: bind to 30S ribosome in turn with a protein synthesis. Efficacious luminal amoebicide. Last, pharmacokinetics discussed. So there is a oral administration, act in a gut lumen only, free from systemic toxicity, neither absorbed nor degraded, eliminated unchanged in feces. Uses: asymptomatic cyst, passer, and chronic amoebic colitis, along with the metronidazole in acute amoebic dysentery as well as hepatic amoebiasis to eradicate luminal cycle. Alternate drug for giardiasis, especially during first trimester of pregnancy when metronidazole and other drugs are contraindicated. Cryptosporidiosis, effective uncertainly. Trichomonas vaginalis and derma leishmaniasis, used topically. So the side effects are not that much: nausea, vomiting, abdominal cramps. Thank you for watching this video.